a little bit about the economic, or the ergonomic, well maybe economic too, but the ergonomic ravages of surgery on surgeons. What we can do and how well it works. And again, there will be a bit of overlap between the prior speaker, but it helps to reinforce it. As you already heard, the study of ergonomics is essentially the study of men and women and the workplaces that they occupy. And one of the points, that this is a very limited discussion, this is something I like to talk about a lot, and I've written a lot on this, and one of the points I make is that when you look at high stakes work environments that humans occupy, I will submit to you that there is no other high stakes work environment that humans occupy that is less understood and has been less studied than the operating theater. When you look at the cockpit of an airplane, when you look at the control center of a nuclear power plant, these workspaces are so well understood. Workflows are so well studied. And in the operating theater, we're back in the Stone Age. So we wrote this paper many years ago, well, maybe about 10 years ago, and it turned out to be a pretty important paper. I had set up, when I was at the University of Maryland, I had set up the first lab for the study of surgical movement. We had the visual tracking systems, the digital visual tracking systems. We had force plate, we had surface EMG, corneal tracking, all sorts of stuff. We did a lot of basic work in terms of understanding surgeon posture, surgeon movement. And we published a lot of it in the ergonomic literature, and none of you or your colleagues ever read it. So decided that to make this closer to home and more relevant, we did a survey about 10 years ago on how surgeons who adopted lap surgery, how they were doing. And the reason we did this was that the early days, and I think some of the papers were cited in the prior talk, the early days of laparoscopy and the early days of adoption, Ramon Berger and others wrote about, hey, lap surgery seems to be good for our patients, but there are some surgeons who are reporting injury and pain related to surgery. Now at that time, the high water mark was maybe somewhere between 10 and 15% of surgeons who did a lot of laparoscopy felt these symptoms. Well, about 10 years after this, we did our study. The adoption rate of lap techniques had significantly increased, so we decided to try to do a new and broader study to look at demographic factors and symptoms suffered by laparoscopic surgeons. So we collected an awful lot of data. This is an international study, mostly North America and European surgeons, where most of the early adoption had taken place. We did all sorts of analysis, found all sorts of things that were fairly predictable. But the punchline of this study was, have you ever had any physical discomfort or symptoms that you would attribute to performing surgery, to going to work every day as a surgeon? And if you remember that Ramon Berger came up with a number of about 10, 12, 15%. When we asked this question for this study, 87% of surgeons responded in the affirmative, that they do suffer symptoms related to going to work every day. Now, this is like a really big deal because, again, we don't have time in this brief discussion to talk about the fact that I'm sure it's the same in Egypt and in every country you come from. This is very much the same in America, in Canada, in France, and in other countries, that the workload of surgeons is doing this. As we have, particularly in the West, an aging population, the workload of surgeons is doing this. The surgical workforce is doing this. And so we're having a separation, a delta increase every year between surgical workload and surgical workforce. And so the reason I bring this up is because when we talk about the ergonomic ravages of surgery, surgeons simply going to work every day, this is not just surgeons whining and complaining. This is a potential healthcare crisis. And so there are many more stakeholders in this discussion than just surgeons. Hospital administrators, healthcare policymakers, ministers of health. If we lose surgeons, if we have surgeons with shortened careers, then that delta between workload and workforce only gets more important. So in raising this topic, there are many people involved who may not realize yet that they are in fact stakeholders to this issue. And I think that nothing less than career longevity is at stake for many of us. And again, if we have time afterwards, I'm going to have to move through quickly. If we have time afterwards, we can talk about this. The number of testimonials I will get from surgeons when I write on this and speak on this about how their practices have changed over time, it's very concerning. Now, when we came out with these numbers, these were so different from anything reported. People were wondering, well, is this real? Well, there have been many studies since then that have corroborated our numbers, where whether it's gynecology or urology or any of these other fields, we're now seeing reports of injury and pain and symptoms related to surgery north of 80 and 90%. So ours was the first finding, but is by no means unique in terms of finding. Now, to Dr. Francis' comment earlier, I have to come with this. There's very few studies that are actually looking at lap versus robotic. This was one from my PhD, my lab PhD, Yusung Lee, and this is a few years ago. But interestingly, you would think that when you can purpose design the workspace, the console for a surgeon, then you should be able to design out all of the major ergonomic issues. But in fact, you see with these patients, with these, you see with the survey that in fact, a large proportion of these surgeons continued to complain of symptoms. Now, there's many reasons for this. So what's happened, we only have one robot in the market, and this is a terrible problem. They are a monopoly, they act like a monopoly, and it's a terrible problem. And what has happened is that because the console is designed as it is, we are now seeing injury reports similar to people who work in the lab and work at a microscope all day long. So you are going to see with the new consoles coming out, I've consulted on a bunch of these, the new consoles coming out, you're going to see that we're not sitting at a microscope. It's going to be a lot more free, and as well, what's happening with the intuitive console is instead of having low back and pectoral girdle and other issues, you have now finger issues and you have C-spine issues. So there's a lot of opportunity to improve this. I've talked with Intuitive for many years and they won't budge on this, so that's fine. Other consoles are going to be coming to market soon and they're going to be better than this, but the current robotic console is by no means a solution. So what can we do about it? We're way behind the rest of industries. Even in office work, they've understood the importance of ergonomics, not because they're better people than us, but because they know that it affects cost and performance of their workers, and so they pay attention to it. And again, in the healthcare arena, the people that we work for have not yet paid attention to this and need to. So what can we do with surgeons? Again, the prior speaker has talked wonderfully to these issues. I'm not going to talk to them anymore in terms of monitor position, foot pedal, etc., height. One of the things that we do need to do is we need to maintain our carrying angle, 90 to 120 degrees, but the main thing in laparoscopic surgery is we abduct our arms a lot. We AD abduct them and we hold them in static positions, and this is terrible. And we also flex and ulnar deviate. We flex and ulnar deviate our wrists and hold it in static position. This is why we have so many problems with wrists. So there's a lot of basic things. There are also things, we have not, one of the points I make is we have not seriously revisited the surgeon-patient interface in about 1,000 years. We still essentially stand beside a marble slab and operate on our patients like we've been doing for 1,000 years. There's opportunity there to revisit that interface. I believe there's going to be high-tech and low-tech solutions that we can look at. We've seen some of the low-tech ones. You've heard a little bit about TSMBs, and I'll talk about that in a minute. So these are the things that my prior speaker spoke about. I'm not going to talk about handles other than we developed a handle that hopefully will come to market soon. And there's many aspects to this handle that we developed. One, which was decades overdue, is we actually developed a handle per glove size. So for the women, the men with the smaller hand sizes, we all had the big old handles, and now we've developed a laparoscopic handle that has, per glove size, so it fits the smaller hands, medium hands, whatever. Ideas that have been tried in the industrial workspace, exoskeletons, for example, have been tried. And in the industrial workspace, you can see here examples of them. But what they found was they work well for static jobs and tasks, but not well in the dynamic workspaces. And so here's an example out of UCSD, Santi Horgan. These guys are wearing, these are residents wearing exoskeletons. And again, you know, not much in the way of benefit for us. There's too much movement in surgeons, but I think it's important to be thinking about new things we can do. This is a surgeon a urologist from Oregon who sent me this. This is called the Ethos platform. It's like riding a horse, but it's putting you over the patient. Obviously, this has not taken off. None of you have seen this or used this, but I applaud him for trying a new way to interface in the surgeon-patient setup. So I'll finish up then with the one low-cost intervention that has really been proven to make a difference, and this is the targeted stretching micro-breaks that was already mentioned to you. And what we did with this study is we had multi-center studies, many hospitals involved. Any ergonomic research is very labor-intensive. It's very labor-intensive. And so what we did with this is we devised a series of stretches. We worked with an exercise physiologist. We've done a lot of survey studies in the past, so we knew where the main targets for pain and injury were for surgeons, and we designed a series of intraoperative exercises that could be performed while maintaining sterility and could be completed within less than 90 seconds, and that addressed the areas, the main targets of surgeon-reported pain. And then we had surgeon-controlled experiments. So one day they had their normal list where they did it normally, and then another day they had their normal list and they employed TSMBs every 20 to 40 minutes. And then we looked at the results. Now, here's an important point. So this was just a few years ago we did this study, and these are the average pain scores when these surgeons, whether they were open surgeons or MIS surgeons, when they started their workday. And I'll ask you again, what other workplace, particularly what other high-stakes workplace where so much is at stake, would the employer allow this level of pain? So surgeons starting their workday at almost 5 out of 10, self-reported pain. We have an issue here that needs to be addressed. So anyway, back to the study. Here's one of the things that we looked at. What do surgeons do to counter the pain? They'll change position, they'll do stuff. A quarter of them will just ignore it. Most of us will just a lot of us will just ignore it. And here are just, you can go find these online. Here are the series of, we've kind of documented them, what these different stretches are, and that can be done. So the results were that when the surgeons employed TSMBs, their pain scores in all anatomic regions were improved. And you can see this is just the pain score improvement in all these regions. But here's some really important things. So most of them saw improved in their pain scores. 38, almost 40% of surgeons reported improved mental focus. Well, I don't know about you, but if I'm a patient, I want a really bright, fresh, focused surgeon operating on me. And if there's things that we can do to improve that focus, then we should do it. Almost 90% of the people involved in the study said they're going to continue doing these after the study. And the pausing to do these TSMBs did not significantly increase the mean OR time of the case. So obviously this is a good thing. I continue to do it. Most of us have been involved in the study. I speak on this a lot. People are doing this more and more. And the next steps are to start to find and tailor to your specific needs and your specific injuries a set of exercises for you. So surgery is a contact sport. Even in the lay literature, people are realizing that we're like the endurance athletes of medicine, and we don't train to meet the physical demands of our job. We need to understand these, and we need to start engaging in strength training and stretching, even apart from the OR surgeons. And I'm just gonna come to the end here. So there's an awful lot at stake. not just for us, but for healthcare policymakers, we lag way behind other industries in understanding our workspace and improving the human factors issues and ergonomic issues around it. Again, for the young surgeons in the audience, this is ripe area for research and contribution, and I'll encourage you along those lines. And even though a lot of this seems like very dire data I'm reporting to you, I still say with complete optimism, I could not imagine a more noble and fulfilling career choice. We just have to make it better for ourselves. And I thank you for your attention. Sorry for
Again, thank you for another excellent presentation, as usual. Actually, when we talk about ergonomics, we always stress on the physical stress. I mean, the neck, the wrist, the low back, and so with very little mention on the psychological and mental stress. These have been tested before through oculomotor testing and skin testing, something like that. But my question is, of course, we all know that from this point, laparoscopic surgery is much more stressful than open surgery regarding the mental and the psychological stress. But what about the move from the laparoscope to the robotic surgery? Because I think the control, as a surgeon can feel, is less in laparoscope than in open surgery. As a feeling. Further, with the robot, the control is much less, to my understanding. So, what do you think?
So, these are good questions, and I didn't have a chance to get into this, but what you're speaking about is a very important issue, and it's about cognitive workload and the distraction culture in the operating room. And again, we tolerate in the operating room a culture of distraction that no other high-stakes workplace tolerates in terms of people in and out of the room, in terms of ancillary discussions, in terms of noises, this and that, and the other thing. And we also pay very little attention to cognitive workload, and this is where stress arises. So whether you're doing open, lap, or robotic surgery, we have to optimize, minimize the cognitive workload, and we have to not just minimize, we have to eliminate the distraction and disruption culture that we accept in the operating room. That's a whole different discussion and a very important discussion.
Thank you, Mr. Adrian. I am Dr. Blazard from Jordan. There are two facts you said. Medicine as a profession is lagging behind the other sciences. That's true. And you say that we should work in the future. What do you think about making theaters in the future with a reduced power or force of gravity in order to work with more ease, such as in the airspace like this? For the science and everything to fail. We know that there's some technology which we didn't see now. It is in the war, weapons like this. But I think all we are suffered, the old surgeons, we suffered from all these mistakes. But I think we have to think about the future to make something in the theater itself in order to reduce all these forces. Thank you.
Thank you. Thank you for the comment. I'll very briefly say, I've been involved in funded research for over 20 years on the operating room of the future, and we've had various, and I can tell you offline if you're interested, we can talk about this after this session. This is why I said in this discussion there will be high-tech solutions and there will be low-tech solutions. The high-tech solutions have been 20 years plus in development. I don't see anything right around the corner, but it's fun and important to ideate, to vision cast, and to think about these things. I can tell you some pretty funky things afterwards that we have tried if you want to know.
Thank you again. It was a pleasure to hear you present the second aspect of surgery, which is what about the surgeon? Not only like your first presentation, what about the patient? The other thing is, have you had any studies to compare open surgery versus laparoscopic and robotics. I initially thought you were going to be much in favor of robotic surgery because of the hype around, oh, we are giving you 6 degrees of freedom at a big cost, but more ergonomic. So a study that would be comparing all three might give us more insight. And as the last comment, I hope you're not eating ice cream in your operating room because you mentioned the marble slab.
So there's a growing literature on open versus lap. The robotic is slower in coming. There's a large literature on the ergonomic issues with open surgery. And it's even worse for the orthopods and the vascular surgeons. You wear lead and you increase these factors. So there actually is a fairly sizable literature on open as well.